Hello, my name is Evelina Payabiene. I'm a neurologist, somnologist, and PhD student, and today I'm going to speak to you about sleep disordered breathing in neurovascular disorders and how they could be relevant for primary and secondary stroke prevention. I will be speaking about the importance of sleep in stroke. I will try to explain bidirectional relation between sleep disordered breathing and stroke, how these breathing disorders are prevalent in pre- and post-stroke phase. And I will also stress that not only sleep disordered breathing matters in stroke, but also other sleep disorders. And I will conclude with the take-home messages. So sleep is really important in stroke because it's prevalent in stroke, and starting from sleep disordered breathing, it could affect till 70% of stroke patients, but we can also have other sleep disorders such as insomnia, sleep-related movement disorders such as periodic limb movement syndrome or disorder, and we can also have sleep-wake rhythm disorders, parasomnias, such as REM sleep behavior disorder, hypersomnias, and chronic fatigue syndrome, which is not exactly a sleep disorder, is also common in stroke patients. When we are measuring obstructive sleep apnea, we are using apnea-hypopnea index, events per hour. And if we have it more than 15, we are evaluating the severity as moderate. So it was detected that moderate sleep apnea is prevalent up to 25% of females and 50% of males, and the prevalence increases with age. And the newer studies are telling us that the global prevalence of obstructive sleep apnea, when apnea-hypopnea index is more than 15, is prevalent for 425 million adults, while clinically established OSA syndrome is less prevalent, affecting about 10% of males and 5% of females. When dividing sleep disorder breathing, the most common form of it is obstructive sleep apnea, but we can also meet central apnea and central hypoventilation syndrome. We can also have mixture of OSA and central sleep apnea, and we can observe breathing apraxia, which is impairment of voluntary breathing control when patient cannot hold or take a deep breath, and it can be observed in frontal lobe stroke or internal capsule or basal ganglia strokes. When speaking about clinical OSA syndrome, the patient can complain about snoring. The patient or his or her relatives can observe breathing pauses during sleep, coughing, croaking, choking during sleep. It could be very severe daytime sleepiness caused by continuous nighttime hypoxia. It could be nocturnal sweating and nocturia. In the morning, patient can feel dry mouth and headache, also loss of energy and concentration. And the typical obstructive sleep apnea patient is male, middle-aged, obese, and also having other metabolic comorbidities. When we are evaluating the patient for OSA syndrome, we are collecting sleep-related anamnesis. We're asking about comorbidities and the medications that are used. We're also examining cardiopulmonary system of the patient, counting body mass index, and we can also use the Mallampati score. That is the score which measures the space between the tongue root and the upper floor of the mouth, and we can evaluate how big is the space for air to come in and come out. And higher Mallampati score is related to higher obstructive sleep apnea risk. The golden standard for diagnosing obstructive sleep apnea and other disorders is polysomnography, when different signals are recorded during patient's night sleep. Here we have an example of normal breathing when we are recording airflow from nasal canal, respiratory muscles effort, saturation and pulse from the saturometer, ECG, signal, snoring, and also electromyographical muscles activity from chin and limbs. And we also have electroencephalography for brain activity and sleep staging. But we can also use simplified method for sleep disorder breathing diagnostics, which is called polygraphy. And this is the same as polysomnography, but without electroencephalography, electrooculography, and EMG. Here we see an example from polysomnography of obstructive sleep apnea. We can observe flattened nasal flow and also diminished respiratory muscles effort, and the result is desaturation in the pulse oximeter, and we can also have the respiratory related arousal. We can observe snoring, and here we can see the repeating obstructive apneas. We can also see the example of central sleep apnea when you have a flattening in the nasal airflow, but also no effort on breathing muscles because the central control of breathing is stopped, and we have the result of desaturation, arousals, and snoring. When trying to explain the mechanism how sleep disorder breathing can be a stroke risk factor, we first of all think about apneas and hypopneas. Repeating during the night, they are causing blood pressure fluctuations and increasing sympathetic activity, which then results to insulin resistance and also accumulation of inflammatory and oxidative substances such as CRP and tumor necrosis factor alpha and interleukin 6. And these substances can induce thrombocyte segregation, endothelium lesion, and formation of atherosclerotic plaques. Apneas and hypopneas could also reduce the cardiac output and cause arrhythmias and vasodilatation, which results in increasing of intracranial pressure and reduction of brain blood supply. And sleep disorder breathing are known risk factors for other cardiovascular diseases such as arterial hypertension, atrial fibrillation, heart failure. These comorbidities are common in stroke and increases the risk of stroke. Speaking about animal models showing the relation between sleep and stroke, we have a nice example of a rat model when ischemia was induced in rats, and after this, 12 hours after focal cerebral ischemia, initiation of sleep disorders were performed over 3 consecutive days. Sleep disorders, it means that deprivation of 80% of sleep during the 12-hour light phase was caused, and then these rats were weekly assessed. Their sensory motor function was assessed by a single pellet reaching test, and also there were control groups. Rats with focal ischemia but without sleep deprivation, and also controls, sham control with and without sleep deprivation. And the results were that single pellet reaching scores were worst in ischemia and sleep deprivation group, and bad sleep resulted in a bigger infarction volume and worse motor function. Stroke occurrence has a circadian variation, and it is nicely shown in this cross-sectional observational study from India, where highest occurrence was observed in the late morning from 6 till 12 a.m. and lowest in the late evening from 6 till 12 p.m. for both ischemic and hemorrhagic strokes. The effect and safety of intravenous thrombolysis with alteplase has also shown a circadian variation, and according to multivariate analysis of nearly 500 stroke patients, odds ratios of major neurological improvement were lower when intravenous thrombolysis was started in 6 a.m. till noon interval and noon till 6 p.m. interval, while odd ratios for hemorrhagic transformations were lower when intravenous thrombolysis was started in the noon, 6 p.m. and 6 p.m. midnight interval. Speaking about occurrence of central sleep apnea, the most common reasons for central sleep apnea is known as to be brainstem lesion, congestive heart failure, and medications affecting central breathing control. But central sleep apnea may also be related to carotid stenosis. According to the study performed in 96 patients with asymptomatic carotid stenosis, more than 50% degree, they underwent polysomnography, and the prevalence and severity of sleep apnea increased with degree of stenosis because of a rise of central but not obstructive sleep apnea. And stenosis severity was related to central sleep apnea but not to OSA. I'm very glad to present the very recently published statement done by collaboration between European Academy of Neurology, European Respiratory Society, European Sleep Research Society, and Stroke Organization about the impact of sleep disorders on stroke outcome and risk. This was done from meta-analysis of 88 studies that met the strict inclusion criteria. And the authors of this statement asked various questions. First of all, is sleep disorder breathing an independent risk factor for stroke? And according to 9 systematic reviews and 14 studies, they concluded that untreated severe obstructive sleep apnea doubles the risk for incident stroke. And according to nationwide Danish study of 4.5 million individuals during 10 years, the study was performed, sleep apnea was associated with increased risk of ischemic stroke and myocardial infarction, especially in patients younger than 50 years of age. This study also showed that CPAP therapy was not associated with reduced risk of stroke or myocardial infarction. So another question arises, does treatment of sleep disorder breathing prevent stroke? According to 4 systematic reviews and 4 observational studies, CPAP treatment is not associated with stroke risk reduction in obstructive sleep patients. However, patients adherent to CPAP therapy, so it means using it more than 4 hours per day, may benefit from this treatment. How stroke can cause sleep disorder breathing? First of all, disturbed control of upper airway and muscles of respiration is happening because of wide hemispheric stroke or brainstem stroke. And when anterior part of corpus callosum is intact, it can reduce the sensitivity to CO2. And wide hemispheric and brainstem strokes, especially with disturbed consciousness, can often cause central apnea and Cheyne-Stokes breathing. About 30% of stroke patients present with severe sleep disorder breathing in post-stroke period. And not only polysomnography, but also the more feasible method, portable cardiorespiratory polygraphy, is sufficient to diagnose sleep disorder breathing in post-stroke period. But what also need to be assessed is predictors of sleep disorder breathing in stroke patients and the link between stroke characteristics and SDB and evolution of sleep disorder breathing over time. Multi-analysis of 37 studies showed that moderate obstructive sleep apnea, when apnea-hypopnea index is more than 20, were observed in 40% of patients, and apnea-hypopnea index of more than 30, so severe obstructive sleep apnea, was observed in 1/3 of stroke patients, and it was more prevalent in males than females. Primarily, central sleep apnea was detected in 8%, and it was more common in acute period of stroke. When observing the relation between sleep disorder breathing and stroke outcome, the statement published very recently addresses that OSA is a risk factor for recurrence of stroke or transient ischemic attack, and OSA in stroke patients may be associated with an increase in all-cause mortality and worsen the neurological outcome. How sleep disorder breathing could be treated in stroke patients. One of the first line treatments is continuous positive airway pressure and other positive airway pressure modes. There is also discussions about transnasal insufflation with high flow air and oxygen therapy, especially for central sleep apnea cases. We can also think about oropharyngeal muscle exercise and mandibular advancement devices that should be chosen individually. There are also some surgical options such as ovulopalato-pharyngoplasty. This is a surgical procedure in order to remove tissue and or remodel tissue in the throat. We can also use selective upper airway stimulation when hypoglossal nerve stimulator is implanted, and this stimulator stimulates only the branches of the nerve that protrudes the tongue and excludes the branches that retract the tongue. We can use positional therapy, especially for supine-related apnea. We can think about symptomatic treatment with different drugs. For excessive daytime sleepiness caused by sleep apnea, we can try solriamfetol. This drug is under review of European Medical Agency. Trazodone is the drug that can change arousal threshold, and SNRIs such as fluoxetine and also ondansetron can activate muscle tone. We also need to stress the importance of body weight reduction, which decreases the risk of all cardio and cerebrovascular diseases. According to American Heart Association and American Stroke Association, in their guidelines of 2014, they are stating that sleep study might be considered for patients with ischemic stroke or transient ischemic attack, and the CPAP treatment might be considered for these patients because the emerging evidence are in support for improving outcomes of stroke. According to 2 systematic reviews and 9 studies evaluating SDB treatment effect on stroke outcome, It was concluded that CPAP is feasible in stroke survivors with OSA and may improve neurological recovery, sleepiness, and depressive symptoms. But the main challenge is compliance. And here it is shown that the mean usage of CPAP was 4.5 hours per night. And when the compliance is achieved, the treatment can be satisfactory. So, thinking about primary prevention for patients without no previous history of cardiovascular or cerebrovascular diseases, we need to diagnose and treat obstructive sleep apnea, and we need to try to improve the adherence of CPAP. And for secondary prevention scenario, we also need to diagnose and treat post-stroke sleep disordered breathing and try to improve the compliance of CPAP. Further research is needed to create a multidisciplinary approach for improving sleep disorder breathing diagnostics and treatment. Also, it is important to identify patients with the highest potential from this treatment and to identify the optimal timing and to evaluate the efficacy of other sleep disorder breathing methods for treatment in randomized controlled studies. It is also important to stress that not only sleep apnea matters in stroke patients. According to the study done in my clinic in neurology department, we performed polysomnography for ischemic stroke patients, and we detected the majority of them having sleep disorders and half of them having non-sleep disordered breathing, such as periodic movement disorder. We had one case with REM sleep behavior disorder and also cases of insomnia. And during this Congress, we have a presentation presenting another study on ischemic stroke patients where we are evaluating rest-wake activity and sleep patterns. And when performing polysomnography, we have also detected nearly 37% of patients having non-apnea sleep disorders. And according to the statement by IAN and other organizations, non-apnea sleep-wake disorders may be associated with an increased stroke risk and a worse outcome. So they need to be remembered. So how we should raise awareness of sleep in stroke unit? First of all, we need to ask and hear sleep-related complaints. We can also use specific sleep questionnaires and sleep diary. If the patient is complaining about daytime sleepiness, snoring, and apneas, we need to think about OSA, we need to think about periodic movement disorder. If the patient is having difficulty to fall asleep or continue to sleep, we need to suspect insomnia. If the patient is having insufficient sleep quality or frequent arousals, maybe these arousals are caused by sleep apnea, periodic movements, or parasomnias. And if we are observing paroxysms, movement disorders during sleep, we need to differentiate from secondary epilepsy, parasomnias, and periodic movement disorders. And then we need to proceed with specific sleep diagnostics, such as polysomnography, polygraphy, and other. And when sleep disorders are diagnosed, they need to be treated. My take-home messages are obstructive sleep apnea, which affects 10 to 20% of the general population and 50% of stroke patients, probably increases the risk of stroke and worsens its outcome. And CPAP possibly has a favorable effect on both stroke risk and outcome. Diagnosing and treating sleep disorder breathing could be a primary stroke prevention scope, and diagnosing and treating post-stroke SDB could be secondary stroke prevention scope. And do not forget that there are non-sleep disorder breathing sleep-wake disorders that also need to be addressed and treated. Thank you for listening and looking forward to your questions.
So thank you so much, Evelina, for this nice talk. And now there is some time for questions, and I'll just read some of them up to you. There's a question from Dr. Patty that says, thanks, very interesting session. Thank you for that. So how do you feel stroke patients needing ventilation should be weaned? Should they be kept on CPAP for longer or supported with intermittent CPAP? What do you think, Evelina?
Good afternoon for everybody. I think it's a great session we are going on, and thanks for the question as well. I think it depends on the compliance all the time in all the cases, because stroke patients are the challenging ones to keep on CPAP. So as longer as better, I think. But of course, CPAP needs to be followed, and the therapy effect needs to be followed. And sometimes the polysomnographies or polygraphies also needs to be repeated in order to see how obstructive sleep apnea is changing in post-acute and chronic period of stroke. And also some people after rehabilitation, they are moving more and they are losing some weight. So there might be some changes in CPAP regulation factors as well. So I think it's better to follow them, to make them compliant, and then to regulate the CPAP, the treatment, according to the efficacy.
Thank you. And then there's also another question. Maybe you could see it yourself also, Evelina, but I'll read it up also. It is from Alexis. Since CSA has been linked to carotid stenosis or congestive heart failure, do we know if intervention on these factors is present, such as carotid surgery can improve CSA?
I think there are some studies about this, not like longitudinal ones till now, but there might be both sides positive effect, I should say. First of all, central sleep apnea could help to identify those carotid stenosis cases, and the CPAP treatment can help to reduce the atherosclerotic plaques and then to reduce all the cardiovascular and cerebrovascular risk factors. On the other side, when carotid stenosis is treated either by medication or by surgery, there are also some positive effects for sleep apnea, but I think further studies are needed as far as I know.
Thank you. So there's also another question. This is from Maria Cecilia Lopez. She says, she also thanks for a very important session, so that's good for you, Evelina. She asks, would we study sleep loss as an important factor and to find a biomarker for interaction between sleep disorders and stroke? So she's asking about what sleep loss is an important factor to probably use as a biomarker for stroke.
I think that's very important marker, and as we see on the animal models as well, we can see that sleep deprivation actually causes worse neurological outcome after stroke. And what we see in human studies, it's already stated that sleep deprivation is one, like chronic insomnia or chronic sleep deprivation is one of risk factors for both cardiovascular and cerebrovascular diseases. It's not that easy to make a studies pre-stroke to diagnose if the patient was already having especially sleep-related breathing disorders and others, but we can ask retrospectively if the patient had sleep deprivation to link it with stroke risk. Anyhow, because of different mechanisms, of course, it is a risk factor as well.
So thank you. Then there are many questions for you, Evelina, so that's very good. Mauna asks, what is the best timing to screen for OSA after stroke?
That's still a discussion, because as we see also in our clinic, in the acute period of stroke, there is of course high frequency of sleep-related breathing disorders. Later on in the post-stroke period, like 3 to 6 months and 12 months even, the frequency is getting lower, and it can be related directly to the ischemic lesion itself. But I think it depends on the clinical practice, but as soon as it's feasible to do a sleep study, it's better to do it, because I think if you are having patient in stroke unit and later on you will be not following him or her, he will go to some like rehabilitation clinic. So maybe it's better to identify this risk factor in the acute period of stroke and then to follow the patient and then to repeat the sleep study if it's needed.
The questions keep coming in and we still have some time. This is Elena Wentz asking, in which selection of patients can hypoglossal nerve stimulation be an option?
I'm not actually the specialist in this specific treatment group to comment very precisely, but CPAP alternatives are always discussed when the CPAP compliance is not good or the patient refuses to have CPAP compliance, or they may be also obesity as the factor as well. So it really depends on the situation, on the anatomical features of the patient as well, and it can be chosen individually. But I think here we need to have, again, like always in sleep, group of specialists treating. So pulmonologists and ENT doctors and sons who can help by identifying the perfect candidate for stimulation.
Thank you. Another question is from Joshua, and asking, in your opinion, what is the optimal suggested timing for repeating the PSG, the polysomnography, after the acute phase of stroke? So when should you repeat the PSG after stroke?
I think, again, I will repeat that it depends on the clinical practice, but the most significant way of doing it, I think, in a practical way, should be in post-stroke period. I mean, like 3 to 6 months after stroke, because later on it shouldn't change that much. So I think like in half of year time.
Thank you. And another one, it is from Zero. Do we have any studies on the effect of CSA on stroke prevalence post-aortic valve repair?
As far as I know, we don't, but I need to check. I can answer it in the written version later on.
That's good. And then the last question is from Jimmy, who says, can CPAP therapy improve neurological symptoms in acute stroke with OSA or CSA?
So as I mentioned in my presentation, according to the statements analyzing multi-analysis, many reviews about CPAP efficacy, if a patient is compliant and if the usage is significant and satisfying, so it can actually have a positive outcome and positive effect for stroke.
Yes. So I think that and now we have had two really good sessions, or at least I think so. I talked one of them myself, but thank you also for all the questions. If we don't have time to answer them right now, then we will as Evelina said, we will answer them after the session. Right now, we have session break, and the session will continue again at 4:45, 16:45. So until then, there's a break, and talk to you later. Bye for now.
Good afternoon, everybody. It's a real pleasure to be here to present on sleepiness and daytime falls, a video session on the differential diagnosis of suspected narcolepsy. We know from the current classification of sleep disorders that narcolepsy should be classified in narcolepsy type 1 and type 2 based on the presence of cataplexy, that is the pathognomic symptom of narcolepsy type 1, or alternatively, the presence of cerebrospinal hypoprotein deficiency. On the other side, cataplexy should be absolutely absent when we make a diagnosis of narcolepsy type 2. We know that the clinical suspect should be confirmed by objective criteria, and the main neurophysiological finding is the presence of a pathological sleep latency with multiple sleep onset REM periods at the multiple sleep latency test. Alternatively, we can use, of course, the cerebrospinal hypoprotein 1 assessment as a main objective biological marker. Cataplexy is the typical symptom of narcolepsy type 1. Here you see a patient, a nice woman is entering in the lab, and he is experiencing a complete and generalized paralysis. As you can see, the muscle recorded show the complete atonia, and the patient will stay for a while recumbent with absolute impossibility to move any part of his body. This is a phenomenon occurring during wakefulness, as here nicely shown by this old-fashioned recording. Then the tone is resuming slowly, and the patient will be, of course, able to explain what was going on while he was feeling paralyzed. Finished, and he says yes. In children, cataplexy can be an early sign, but it's most frequently something with specific characteristic that we will discuss, and most frequently it occurs acutely in a context of a more complex movement disorder. Sleepiness in children can present differently because the children can have an increase in the need for sleep during the night, and start again to napping during daytime, and the MSLT is most often diagnostic. Otherwise, there is a complete inability to stay awake during daytime, and in the night we see a lot of awakening, very prolonged in time. Once again, the MSLT here is pathological despite long napping in between the MSLT. Sometimes children may have an inner reaction to sleepiness, making them very irritable during the day and masking completely the presence of sleep attacks and sleep episodes, like in this child. And during the MSLT, once again, we see that the MSLT was able to evidence the presence of sleep onset REM in most of the naps. Cataplexy at symptoms onset is very different from the picture we have in adults. This has been described for the first time by the group of Professor Plazzi in 2008, when he noticed that the face of these children is typically characterized by ptosis, an opening of the mouth, a protrusion of the tongue, a complete hypotonia of the face, and that these phenomena were most frequently spontaneous or present during activities that do not have anything connected to emotions like walking. Here you see a child whose history was not characterized by cataplexy, mainly because when he was having cataplexy, he was on the sofa watching cartoons, and here, when questioned what happened, he said, nothing. And I just flew on the floor. Here you see another child that is having a lot of lip movement, an hypotonic standing position, a lot of fluctuations, and this is intermingled by more phasic atonic moment, up to, you will see here, a brief fall. These negative motor phenomena were not isolated. We make a collaboration with Professor Bhatia in London to describe the complex picture of active motor phenomena that were intermixed with these